This is it. This is the moment you've all been waiting for. Finally, we can put everything we know about infant sleep and EEG to slave to stage sleep studies. Um, go into all this stuff about staging and scoring, not as you know afraid of it. This isn't anything to be afraid of. Oh, we're talking about pediatric and infant sleep study. Oh, it's not that big of a deal. It's the same kind of stuff that we do for adults. It's just a tiny bit different. You should go into it with that attitude. Let's review a few terms about ages. Some we've heard and some we haven't. There's gestational age, which is the time elapsed since the mother's last menstrual cycle. Conceptual age is gestational age at birth plus the number of weeks postpartum. So basically the entire duration from missed cycle to present postpartum. Chronological age, or postnatal or legal age, is time elapsed since birth. Infant sleep staging rules should be used to score sleep and wakefulness in infants up to 2 months old, or 37 to 48 weeks conceptional age. Just so there's no confusion, if you consider a baby born before 37 weeks, it's considered premature. Before 37 weeks is premature. Baby born at 37 to 42 weeks is full term. Post term are babies over 42 weeks gestational age. As we've discussed in the infant EEG characteristics, the EEG changes with age, sometimes in just weeks. And you should know which waves are normal and which aren't, so you can identify an anomaly and get the patient or get the physician to help quicker. Certain EEG milestones are also helpful in determining the infant's neurological development. All the technical specifications as far as how the montages are set up and where to put the wires, they're all the same, with the two exceptions as we've heard a million times, and this will be 1,000,001. For the chin EMG, reduce the space between the electrodes from 2 centimeters to 1 centimeter, and also reduce the EOG from 1 centimeter to 0.5 centimeters away from the eye. Also, sleep spindles are asynchronous because of an underdeveloped corpus callosum at this age and until 2 years old. And the desired signal to get spindles may be easier to see in the midline central derivation, so the physician may require extra CZ wire derivations, including C3 to CZ and C4 to CZ. Let's get super basic. Sleep needs to be scored in 30-second epochs and stage each epoch of sleep corresponding to its stage. That's pretty basic. If there are signs of more than one sleep stage, score the epoch with the stage that takes up the most amount during the epoch. If you're not sure if the stage is REM or non-REM, R or N, quiet or active, you may score the epoch as T-sleep for transitional sleep. Sleep onset should be considered the first epoch, not scored as wake. Anything else. Some labs or research protocols require sleep onset to have at least 3 contiguous epochs, which are back to back to back, 3 contiguous epochs to score sleep onset. But the AASM infant rules require just 1 epoch of any kind of sleep. And we should know that infants usually enter sleep in REM. Here's a nice table of AASM terminology to describe sleep stages and their characteristics. To stage wake, you're looking for things like eyes open, crying, feeding, and irregular respiration rate, low voltage, irregular, or mixed frequency on the EEG. The EOG will show REMs, rapid eye movements, blinks, or scanning eye movements, and there should be chin tone present in the chin EMG signal. For N sleep, also known as quiet sleep, there is reduced movement related to wake as well as stage R. There are regular respirations, and as for the EEG, you should see trace alternate, high voltage slow wave sleep or delta waves, sleep spindles, and mixed frequencies. There should be some chin tone, if not relatively low. Stage R sleep shows irregular respirations, as does REM sleep for adults. The EEG shows low voltage, irregular, or mixed frequencies with some rare high voltage slow waves, and low chin tone, usually the lowest chin tone. I've had this in a previous presentation, but this is a good representation of differences between four of the common EEG patterns you see with infants. High voltage slow waves are like adult slow wave sleep, but much higher in amplitude. Low voltage irregular is similar to LAMP, but the frequencies are not as mixed. You just see maybe one or two other frequencies. The waves may vary from delta to theta, but they really don't have alpha or beta frequencies except for delta brushes and some spindles. Trace alternate is the burst of delta waves and the interburst sections that consist of the waves at least 20 microvolts in amplitude. Remember, trace discontinue, how did I say it? Discontinue, something like that. Trace discontinue, you could just say it like that. It's where the activity in between the bursts of delta are lower than 25 microvolts. The scoring manual also includes an assortment of behaviors as we covered in the infant sleep characteristics presentation. It's included because wake and wakefulness in infants 38 to 48 weeks conceptual age are scored based on not only the regularity or irregularity of respiration, the EEG, EOG, and chin patterns, but also based on behavioral observations. During active or quiet wake, you will notice eyes open, scanning eye movements, and sometimes brief eye closure when they cry. Otherwise, eyes close equals sleep. For in sleep, the eyes will be closed, sucking can occur, but there are very few movements. During R sleep, the eyes are closed, rapid eye movements can be seen under the closed eyelids, some squirming, sucking, grimacing, and other small face or limb movements is normal. Here's a table from the scoring manual that includes the EEG characteristics seen in sleep. Instead of separating them by sleep stage, it's based on either continuous or discontinuous and other waveforms of interest. If you'll remember, trace alternate is a discontinuous EEG waveform, meaning it will have relatively low activity, but in this case the lower activity is at least 25 microvolts, and the bursts of delta last somewhere between 5 and 6 seconds. Trace alternate is commonly seen in stage N. Low voltage irregular is a continuous low voltage mixed frequency with some delta but predominantly theta, seen in R and wake. High voltage sleep waveforms or high voltage slow waveforms are continuous, synchronous, and symmetrical high voltage 1 to 3 Hz delta. Mixed waveforms show both high and low voltage with mixed rhythms. The amplitude will be lower than high voltage slow waves, and it's seen in wake and REM, but rarely in sleep. And finally, sleep spindles are trains of 12 to 14 Hz activity, usually seen in the central derivations and only occur in stage N sleep. Central derivations mean the C's. Because infant EEG can be difficult to read because of the nuanced appearance with ages, you can use the respiratory signals to assist you in staging sleep more accurately. The patient is really only going to show regular sinusoidal respirations during N sleep, but during wake and REM, they will show irregular and some shallow breathing, and in REM, they will also have some central apneas or hypopneas. A lot of these central apneas may be scoreable, but it's up to the medical director of the lab to whether they think they're real or not and should be scored. We also use the EEOG to assist in staging sleep. This table is also from the AASM manual. You will see eye blinks, scanning or reading eye movements or rapid eye movements during wake, and rapid eye movements in REM as well. Remember, conjugate means moving together. Eye blinks are conjugate vertical eye movements at a frequency of 0.5 to 2 hertz present during wakefulness with eyes open or closed, vertical, up or down. A lot of times I think I get vertical meaning just up, but it also means down. Scanning eye movements are trains of conjugate eye movements with eyes open consisting of a slow phase, which is moving slowly side to side, following by a rapid phase in the opposite direction to look at the next sentence or the next page. That's what's happening there. As the infant visually scans the environment or follows objects, they don't have to be reading. Infants don't really read, but they can follow, and you may see some scanning eye movements when the infant is awake. Rapid eye movements are movements that are recorded in the EOG consisting of conjugate, irregular, they don't happen in a pattern, and sharply peaked eye movements with the initial deflection lasting less than 50 milliseconds. REMs are a characteristic of our sleep and wakefulness. Why do we have the less than 500 milliseconds deflection thing? We have to distinguish eye movements from waves because the brain waves can show up through the EOG. So this is one way to make sure that this is what it is, and not like even a slow rolling eye movement. We also use the chin EMG signal to assist us in staging sleep and wake. Low chin EMG tone is considered the lowest EMG of the entire record, usually seen in stage R. REM also might show some transient muscle activity. Transient meaning spontaneous or out of nowhere. Transient muscle activity is short, irregular bursts of EMG activity, usually lasting longer than 0.25 seconds superimposed, or 25 milliseconds. That's what that would be. Superimposed, or meaning on top of the low EMG tone. The activity may also be seen in the chin or anterior tibialis EMG derivations, which are the leg wires, as well as the EEG or the EOG derivations. Transient muscle activity in the EOG indicates activity of cranial nerve innervated muscles, facial and scalp muscles. The activity is often maximal when associated with REMs. Here's an example of an 8-week-old's sleep spindles. They're not as big as adult sleep spindles, but and something interesting about these sleep spindles is that they're occurring pretty much at the same time. The corpus callosum is not usually fully developed yet, so it's more common to see asynchronous sleep spindles. So that's kind of interesting. Here they are. They start over here. They're very long. Very long. Here's 16-week-old sleep spindles. They kind of look like alpha, but they have greater amplitude, meaning they're taller. A lot of these spindles at this age can be characterized with a rounded top and a positive discharge. This is where it's coming from. It's got a rounded top and then boom, spike, round, spike, round, spike. Young sleep spindles. And they're asynchronous as well. See, they're happening here, but they don't happen here until over here. 3-month-old spindles here. They are some long sleep spindles. Look at that. It just goes for most of the page. They're up to 10 to 15 seconds. I believe this is a 15-second screen. And these are EEG screens, 15 seconds windows. That's what EEG people look at. So they'll look tighter during a sleep study, but still, that's a really long sleep spindle. Here is an example of 36-week-old trace alternate. Trace alternate is periods of relatively low activity, although in trace alternate, those lower activity periods must be in amplitude greater than 25 microvolts, and the bursts of big waves will be delta, or slow waves. Same thing. Here's more trace alternate in a good section of low voltage portion interburst followed by delta waves. This is a record from 25-day-old. You need to confirm that this is just trace alternate in the EEG. You can do that with respiration and other things, because this you might confuse this with an arousal. I don't really see a PDR, but a lot of technologists will say, "Oh, that's an abrupt shift in the EEG," and where that might be true, I don't see a PDR. I don't see a lot of movement. The heart rate doesn't do anything different. One of the eyes is out here, but I don't see anything else that would be that. So another reason why you need to have everything there so that you can tell if something's real or not. Is this an arousal or not? No, this is trace alternate. Wake is most reliably scored by behavioral observations because many of the distinctive EEG features of wakefulness are not seen until after 2 months old post-term. Really, if the patient's eyes are open, they're awake. If they have sustained muscle movements, they're awake. Sustained, not very quick and rapid. In the EOG, you'll have scanning or rapid eye movements and sustained chin EMG tones with bursts of muscle activity when they're making faces like grimacing and stuff like that. Wakefulness, is characterized by an EEG background of continuous, symmetrical, irregular, low to medium amplitude mixed frequencies, which may include 1. Irregular theta and delta activity, up to 100 that's 100 microvolts up to maximum in O1 and O2. 2. Diffuse irregular alpha and beta activity up to 30 microvolts. 3. Rhythmic theta activity up to 50 microvolts, often maximal in C3, CZ, C4, or 4. Most commonly, artifacts from body movements and eye movements. That's what you're going to see most when they're awake. And this may have superimposed movement artifacts also. This is a decent look at wake. There in the first half of this epoch, these signals look like they have a heavy filter on them. The EEG should have a lot more movement artifact, and there's lots of pin blocking, and by the respiration you can tell that they're moving around, and there's the chin tone, they're making faces or something. This should really be a lot darker, because this gives the visual of sleep, but it's not until over here. Look at those waves. These waves are also kind of moving up and down a lot more. There's pin blocking from how big they are. But here, there's normal respiration, so this looks more like sleep with those waves. So that's wake, and they've noted that they're about the behavior of eyes open and they're moving their head. And where you see that pin blocking in the middle there, that's where the voltage of the muscles and the scalp are much greater than the EEG waves, and that the signal literally goes off the chart. And the pen can only go so far on paper, so it just holds that highest or lowest places. And again, this is how you confirm if a patient is asleep or not. Use everything available. The chin looks like even the heart wires are getting some tension on them. That's what that darkness is. They're kind of pulling on it somehow. Do all that and explain why you're saying someone is awake in the documentation if it's not very clear. If it's close, but you still think you're right, type in the notes in the study while you're staging things so that the reading physician understands. To score stage N, you must have 4 of the several listed options. Eyes closed with no eye movements. The chin EMG in stage N is variable. It is generally lower than wake and higher than stage R. That is, if the chin EMG activity is present, this is evidence for stage N. However, stage N can still be scored with low EMG tone provided at least 4 other criteria in stage N, including regular respiration, are met. EEG-wise, you're looking for trace alternate, high voltage, slow sleep, or sleep spindles. The amount of movement should be reduced relative to wake, especially active wake periods. Regularity or irregularity of respiration during sleep is the most reliable sleep study characteristic in telling the difference between stage N and stage R. Here's stage N. You see some K complexes here, actually, and they're so big that it hits the pin max and gives pin blocking squares. There also appears to be some beta activity right there. It also kind of looks like trace alternate as well with it kind of looks like a delta brush there. The chin is low. It's not super skinny though. These are regular respirations. Let's look at the effort. Boom. Very regular. It's a pattern. It's a dead giveaway for stage N. The technologist noted that the patient's eyes were closed and had no movements, so that also confirms stage N. Here's more stage N. The amplitude is higher, so we can really classify this as high voltage, slow, or continuous delta. There are no eye movements. In fact, what you see there are just the brain waves that are close enough to the EOG electrodes that they're providing the deflections. Those are not the eye movements like that. There are regular respirations. There's the effort. And it's pretty small there, the chin tone. It's low and steady. You can almost see these little blips right there. That's the EKG artifact. So if it gets even smaller than this, you'll see that EKG artifact even better. And that'll really give away the low chin tone if you see the heartbeat in it. The technologist notes say on this record that the patient has their eyes closed and there are no movements. Scoring stage R when there are stage R when there are 4 or more of the following criteria, but it must also include low chin tone and irregular respiration. One must have the lowest chin tone, the eyes closed, and must have rapid eye movements or clicks along with low chin tone. It can't occur during an arousal. You can have mouthing, sucking, twitches, or brief head movements, but they're rare in N to score N, and the EEG will exhibit a continuous pattern without sleep spindles. Occasionally, delta can be seen in infantile REM, although it's low voltage, irregular, or mixed for the most part. In infants, the first epoch of sleep is most commonly stage R. Given the difficulty in determining sleep onset, and because wake looks a lot like REM in most cases, an epoch of definite stage R is required to begin scoring this sleep stage. Definite R means you have to have low or medium amplitude mixed frequency without spindles and trace alternate. The chin tone is low for most of the epoch, and there is no intervening arousal. You can score R without REMs in that situation. Here's some eye clicks in phasic stage R. You can correlate the eye movements with the irregular breathing. Here's an eye movement. Here's a little bit of irregular breathing. There's some eye movements. Here's a little bit of irregular breathing. These aren't very fast clicks, so I don't know if those are eye movements. That might be artifact because, see, look at the respirations. Those are regular. Look at the chin tone. Look at how small and skinny it is. You can see the heartbeats almost every time they occur. That's EKG artifact. The EEG looks like low voltage irregular. Pretty nice right there, especially, yeah. The technologist notes tiny movements of the mouth, so that's all indicative of REM. If you can't tell if there is more stage W, stage N, or stage R in any given epoch, you can score an epoch as T for transitional. To qualify for transitional, it must contain either 3 N or 2 R characteristics, or vice versa, with 3 R characteristics and 2 N characteristics. The chin tone here looks pretty low, like REM. The respirations are semi-irregular, and the EEG shows low voltage irregular. However, there are also no movements and no discernible rims. So we have 3 rim characteristics and 2 in characteristics, and that qualifies this epoch as T. So we don't stage arousals, we score them. But again, like I did last time, I highly encourage you to score the arousals as you go through the staging phase of analyzing the studies. You can't see the true PDR at a 2-minute window, which most technologists use for respiratory. Usually they either blindly associate a respiratory event with a darker place in the EEG as an arousal without even looking to see what the real EEG is. Also, once you score the arousals and then you go back and mark the respiratory events in the second pass, the arousals will automatically revert to a respiratory arousal for the report instead of a spontaneous arousal. It's a great way to make sure the events actually cause arousals right when you say they do. Marking arousals in the 30-second epoch also helps you determine the stage by showing how much of the epoch belongs to which stage. And guess what? It's over. Study this material hard, complete the assignments, and the test is there when you're ready. If you have any questions about any of this stuff, if you want some more explanations, give me a shout with text me or send me an email, all right? We'll do it.